Now we close his eyes, and again, make sure he's not going to fall. Have him kind of shake himself out a little bit. Just, you don't want him to, eyes closed. You don't want him to orient himself with the surroundings. Now, what I'd like you to do is I'd like you to look at the earlobe. See, there's one ear lower than the other. That's their head front. Take a look at the shoulders. There's one shoulder higher than the other. Take a look at the scapula. Is one scapula higher or protruding more so than the other? Take a look at the ribs. The ribs look like they are a little bit more pushing and tighter on one side than the other. Take a look at the hips, and again they would be in their underwear at this point. Look at the top of their underwear. Does it sit on their hip the right way? It has a tendency to level. Take a look at their feet, and do they have their feet broad stance more like he does? And does he have one leg or so turned out? That'll give you an idea of pelvic connectivity. Now, after you've done all that, you got a couple of things you can do. You can take a skin marking pencil, palpate each of the spinous processes and place a dot on them all the way down, or you can take your finger and you can go like this. Turn this way so you can. You're going to go like this a number of times, pressing hard, and when you do that, palpate, you see your fingers deviate to one side or the other in certain areas. But if you do this enough, you're going to end up getting what we call hyperemic marks, red marks. Then stand back and take a look. The marks, are they going up and down, or do they deviate? If there is no deviation, either from the marking or from putting our fingers down, the test is basically over. The person doesn't have scoliosis. But if there is a deviation, ask the patient to bend forward from the waist. Now stand behind them, run your fingers back down again. Did that deviation improve? Did that rib humping change? Did that scapula do a little bit more? Any of these changes tell you that you have some functionality in that scoliosis. Well, that works for you. Any questions? Okay, that's called Adam's position. This is called Beaver's sign. Folks, very simple test. We're going to be looking at the patient's umbilicus. We've got upper abs, we've got lower abs. If the upper and lower abs are doing what they're supposed to be doing, that means pulling together, you're going to find that the umbilicus stays centered. If he's got stronger upper abs, then he has weaker abs. But he's going to be asked to do a slight little shoulder raise off the table where he tightens these muscles, the umbilicus is going to migrate which direction? Up. If it turns out that his upper abs are weak and his lower abs are strong, which way is that umbilicus going to go? Down. So you're going to be observing, if you wish to, you also can palpate if the patient's okay with it, and you can place your fingers above and below like this. That's the patient across the arm, and just lightly palpate, and just lift your head up and a little bit of your shoulders over here. That's it. You're looking, you can palpate right here and feel intensity in the muscle and observe the umbilicus moving. You're going to encircle the patient. You're going to ask them to forcibly exhale. Make it tight. Get a measurement. Then you're going to ask them to forcibly inhale. Follow it with the tape measure. Difference should be somewhere between 1.5 and 2 inches. If you've got 1.5 to 2 inches, you've got good excursion. If you have less than that, we're thinking about something that's preventing that from happening, and the classic thing for that is ankylosing spondylitis. But there are a ton of other things that come into play too. For example, what happens if the person had a fractured rib? Are they going to really be able to inhale and exhale very well? No. How about COPD, chronic obstructive pulmonary disorder? How about asthma? How about emphysema? How about lung cancer? Can the list go on? It sure can. So what you're going to do is you're going to take the tape measure like this. You're going to place it in front of the patient like this. Ask the patient to grab it with their fingers. But what you're going to want to do is bring your elbows up top. There you go. And now place them around T4, your chest level. And now put your arms down. Okay? Now you can make it nice and snug. Now ask the patient to forcibly exhale. And now ask the patient to forcibly inhale. Got it? And take the difference between the exhalation and the inhalation. Should be between 1.5 and 2 inches. Now, how many of you remember doing Soto Hall? How do you do it? Soto Hall. Right. Put your hand on your chest. One hand. Put your hand like this. Hand under here. And do this. Oh, I do the work right here. Now, what level is that good down to? You remember?
T7.
T7. The sister test of this is called Lindner. L-I-N-D-N-E-R-N. So that's the patient scoot back onto the table so their shoulders are all the way here. Now, what we're going to do is you're going to take your hands, place them underneath the patient's shoulder. Let the head rest on you. You're going to force the chin on the chest, and you're going to lift up. With the hands not on the chest, as we lift up like this, we're going to be pulling down below T7. So this is good from T7 down into the lumbar. And this is called Lindner. Ask your patient to laterally flex to the left. This is called Forestier's bowstring. No different really than shuttling. So what I want you to notice is, look what happens to the muscle tone on this side. What happens to the muscle tone on this side? Kind of gets relaxed and flaccid, right? What happens to the skin and the muscles on this side? Gets stretched. This is what you would normally expect to find. What would happen if he had ankylosing spondylitis? The inability of the spine to flex. So if you try to do this, would there be any weakening or shortening of the muscles on this side? Would there be any lengthening of the muscles on this side? The answer would be no. So Forestier's bowstring would be a good test for ankylosing spondylitis. Lewin's supine. Now folks, Dr. Lewin has 5 tests named after himself, and what he does is he always starts off with the name Lewin, that's his name, the first part of the test, but then he tells you what position the patient's in. So you got Lewin's supine, Lewin's standing, okay? Lewin's punch test, things like that. So we're just going to do Lewin's supine. So the patient is supine on the table, hold on to the ankles, ask the patient to cross their arms. Now you can ask the patient to do a controlled, slow sit-up. Very nice. Now, the ability to do this, what happens segmentally? In order for him to be able to come on up and bend forward, what has to happen to the spinal segment? Don't know. Look at the segment is going like this, you have to open up. Now, if he did not have the ability to have those segments individually moved, would he be able to do a sit-up? A condition that this is really good for is ankylosing spondylitis. Ankylosing spondylitis starts from the SI joints, migrates its way up the cephalad, and it can stop anywhere along that line. It starts from the SI joints, making them somewhat immovable, and can lock out the lumbar and make this really difficult for the patient to do. Does that make sense? So the best is a really good test for ankylosing spondylitis. Rib compression. Now folks, you gotta be careful with this. Some people, due to their prior history, don't like you working on them from behind. And if they don't, you just can't do the test, okay? But also, this test here, we're gonna be reaching, we're gonna be reaching around like this. Try to make sure you're using as much of the forearm as possible on the arm so that you're not doing this, because if you do it this way, your hands are too close to breast tissue, okay? So I want you higher up. Explain to the patient what you're doing. We're going to do this. We're going to squeeze lateral to medial. Now, when I do that, which way are the ribs going to bow? Anterior and posterior. So the costosternal and the costotransverse articulation. Shufflement, and the other one is called Forestier's bowstring. Now folks, just like we did the East test that we did this, and the intermittent claudication test where we did like this, the patient was seated, these two tests, the only difference in performance is one standing and one seated. What you're looking for is a little different. So, with the patient seated, we got Sheppelman's test. Ask the patient to laterally bend to the left. On the side of lateral bend, what am I doing to the nerves that go between the ribs? Compressing. So those nerves are irritated. We call that intercostal for rib neuralgia. If those ribs are irritated, then you feel comfortable leaning to that side. Now on the opposite side, now you're leaning to the left, what's happening to the underlying pleura in the lungs on the right side? Being stretched. So Sheppelman, intercostal neuralgia versus underlying pleura. External compression test. Now I need you to think out of the box now. Don't bother looking at the test yet. Place this, your hands on your sternum. Place your hands on your sternum. Now I take my hands and I place them on top of his, and I push down. What am I doing to his ribs? Which way are the ribs going to bow? Excuse me? Yes. If I'm pushing this way, the only way the ribs are going to have to go is going to be this way. What is the most common site for rib fracture? So if the patient had fracture of the ribs in the area of the angle of the rib, would that be painful? Okay? So that's going to be your sternal compression. Spinous percussion and tuning fork. If you're ever asked for spinous percussion in the thoracic spine, you need to be able to show where you're at. So if you want to count down from C2, C7, and say, okay, we got T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and mark them, that's great. Then you take your percussion hammer and you're going to strike each one of those spinous paths. Then homologously hit paraspinal. Okay? Now we're looking again for spinous fracture and soft tissue pathology. If any of this is tender, you can take your tuning fork to 128, sound it, and place it right on its spinous process.